I'm going to be introducing our last two speakers. Before I do that, I've been asked to announce that those who are looking for CE credits, please arrange to do that at the table outside the door immediately after this meeting. First up, or the first of our last two, is a talk by Dr. Robert Kerns, Integrated Precision Chronic Pain Management, Ready or Not. Dr. Kerns has been a friend and mentor for almost 40 years to me. He's a major figure in the area of chronic pain management. He is a professor of psychiatry at Yale and a center director at the VA in VA, Connecticut, with a primary interest in pain management and healthcare for veterans. So without further ado, Dr. Kerns.
So good afternoon, everybody. I've got a lot of slides to whip through. I hope you'll stick with me, and I know this will be a little different than most of the other presentations. I'm a psychologist by training, and I'm going to focus much more on models of care, and particularly the psychosocial components of a biopsychosocial framework. Bottom line here is I have been generously supported by multiple groups, and I have no particular conflicts to declare today. So I want to start by framing, as others have, what I'm going to talk about in the context of three important health policy or pain policy initiatives. One that you've already heard about is the Institute of Medicine's report on relieving pain in America, that was then subsequently followed by a national pain strategy that was initiated really on the recommendations of the IOM committee that really called for the Secretary of the Department of Health and Human Services to launch a comprehensive national initiative to transform pain care in America. Most recently, several in this room and I contributed to another important initiative called the Federal Pain Research Strategy that was only recently published. This was sponsored by the Interagency Pain Research Coordinating Committee that, like the IOM committee, was actually chartered through the Affordable Care Act. The IPRCC is an intergovernmental group with outside experts as well as participating members, selected members, and it provides actually an oversight for many important initiatives in the United States related to pain care, but particularly the focus of this national research strategy is around prioritizing for federal government funded research. And this just tells a little bit about the composition of the group that put together this federal pain research strategy, and it also lists the 5 topic areas that the IPRCC asked this group to work on. So there were work groups around each of those 5 groups. From the Federal Pain Research Strategy, so this was only recently published. I encourage you to check out the website and see it if you haven't paid attention to it. I hope that it will have an important impact in influencing our research agenda in the United States. There are 2 that I'd like to highlight. One is a call for effective models of care delivery for pain management, which highlighted as a statement of the problem that despite the significant burden of pain, effective programs, services, interventions are not always accessible, available, or utilized. And that while clinical research has established some effective and cost-effective chronic pain interventions, there are significant numbers of interventions that have not been adequately evaluated. From those findings, the Federal Pain Research Strategy articulates research priorities, and it labeled as one of its cross-cutting priorities a focus on developing, evaluating, and improving models of pain care. And you see here on this slide that it really talked about the continuum of care from acute to palliative care, and also the continuum within the healthcare delivery system from primary care, specialty care, to tertiary care. And it really emphasized this model that had been articulated within the IOM report and then again in the National Pain Strategy about integrative models of care and team-based care. All of this really is in the context of thinking about a population health level problem that the IOM report and others today have emphasized. If such a large proportion of our population has chronic pain, has pain, and a significant proportion have chronic pain or even high impact chronic pain, then we need to think about models of care that really can be targeting this as a public health or population level problem. So alongside, really almost side by side in the Federal Pain Research Strategy is a second cross-cutting priority area, precision medicine methodology to prevent and treat pain. And defined precision medicine, as you see on this slide, and speaks about it in the context of, one could frame it as a biopsychosocial model. But the last point here, I think, is the important one that kind of sets the stage, maybe somewhat artificially, maybe a straw man. We'll see how the talk goes and your reflections on it. But it does seem to me that it also articulated an approach that encouraged moving from maybe a more generalized population health level model of care, system of care, to thinking about one that is more personalized and individually tailored, more consistent with this idea of precision pain management. So here's the articulation of that research priority, developing approaches, incorporating the precisions of the principles of precision medicine to prevent, effectively treat pain. And you saw in the previous slide the framing within maybe a biopsychosocial framework. But I have to say, when I look at this, I see much more of an emphasis that is consistent with the focus of our discussion today. The framing is one thing, but then the focus being much more on biology and neuroscience and genomic research and the like. So in some, from a psychologist's point of view, maybe we're standing at the cusp of a controversy that I'm maybe wanting to suggest this is true. That is one that would put resources into a public health approach as opposed and one that's consistent with the biopsychosocial framework, and one that may be, for some anyway, a much more biomedical reductionistic kind of approach. So on the one hand, there's a call for this population health approach for an integrated, patient-centered, evidence-based, multimodal, interdisciplinary pain care that's informed by the biopsychosocial model. And on the other, a call for precision pain medicine, implying a specific targeted mechanism-based approach emphasizing biomedical factors. So how to reconcile these approaches? And can we, in fact, from a psychological or psychosocial perspective, think about applying some of the same, can we resolve this controversy by thinking about the ideas of precision pain management, precision medicine, and apply them to the psychosocial domain and things like non-pharmacologic approaches. Maybe it's an artificial dichotomy or distinction for the purposes of this talk, but that's where I'm going to focus my talk today. So what is the evidence about models of chronic pain care, especially a model that integrates non-pharmacologic approaches? So I gave a talk recently at the NIH annual pain symposium that was specifically focused on this idea of integrated models of care. I'm not going to go into that level of detail, but the bottom line is this is what we're thinking about. We're talking about a model of care that talks about the systematic coordination of medical, psychological, and social aspects of healthcare, and includes such domains as primary care, mental health care, and when needed, specialty pain management services. All of this is within, of course, as I've already said, a biopsychosocially informed model of multimodal care. We can kind of label the three domains, biopsychosocial, and label them in terms of things like behavioral therapies, pharmacologic treatment, physical activation. I want to encourage thinking about this as Steve Dobsha from Oregon Health Sciences Center and the Portland VA, and think about including other aspects like promotion of healthy lifestyle, addressing comorbidities, and putting this all in the context of a model of an integrated health system. So really to think about this model specifically in the VA, but potentially with broader implications for at least other integrated healthcare systems, if not the broader private sector, even in the fee-for-service environment in the United States. The VA sponsored what they called a state-of-the-art conference on non-pharmacologic approaches for chronic pain, chronic musculoskeletal pain management. This was really grew out of a White House summit on the opioid crisis, where our then Undersecretary for Health for the Department of Veterans Affairs, now the Secretary of the Department of Veterans Affairs, Dr. Shulkin, stood up and said, we'll take the lead on thinking about whether non-pharmacologic approaches, particularly complementary and integrative health approaches, could help address the opioid crisis. Are there opioid-sparing effects of these interventions? And the SOTA then really kind of grew in its scope to some extent to expand beyond complementary integrative health approaches, but narrowed the scope to chronic pain and then chronic musculoskeletal pain. And you see here the goals, which were to synthesize the existing evidence about and identify gaps in knowledge related to non-pharmacologic approaches to musculoskeletal pain management. And to also, for the VA at least, identify strategies that were, quote, ready for prime time, things that already had enough evidence that they should be available to veterans within this integrated healthcare system, and also to develop a more specific research agenda. To do that, we actually, I co-chaired this with a colleague, Aaron Krebs, from the University of Minnesota and the Minneapolis VA Minneapolis. We actually kind of broke down some of these barriers between, quote, more traditional non-pharmacologic approaches like cognitive behavioral therapy. It's hard to think about that as traditional now, from where I started 30 or 40 years ago, versus complementary and integrative health approaches like yoga, Tai Chi, and others. And so we actually decided to cluster work groups in 3 work groups around different approaches that we labeled as psychological, primarily psychological and behavioral in nature, exercise or movement therapies, and manual approaches, noting that many approaches, even those people that espouse those approaches, would probably not object to this kind of labeling or putting them in one bucket versus another when you're thinking about, quote, mind-body approaches that involve exercise and psychological interventions like yoga, for example. We also had a specific focus, and the one I want to emphasize today, on what are the models of care? What do we know about different models of care for integrating these kinds of approaches? So to summarize the 3 working groups, the group actually did look at the evidence, and you could argue with some of these, but we identified in each of these clusters a finite number of interventions that we believed, or that they believed, could meet reasonable standards of evidence to support their implementation in VA. And you see these on this slide. I'm not going to get into the detail here, and maybe your favorite approach is missing from the list, but it's all a matter of kind of degrees, and also it's important in the context of precision pain management to note that some of these interventions have good evidence for their efficacy or effectiveness in, say, neck pain, but not back pain, or not joint pain, but not something else. So, you know, it's all a matter of kind of one's perspective. The bottom line of looking at these specific approaches, though, was an enormous need for research in these areas. And here's what they listed, and all the recommendations are on this slide, but I highlighted or bolded 2 that I think are particularly important here. One is that really, if you look at across the domain of non-pharmacologic approaches, including all those on the previous slide, there are virtually no data to suggest that one intervention is more effective at a population level or for groups of people than any other. So the comparative effectiveness research simply hasn't been done. And if we're going to move in the direction of precision pain management, then that, of course, is an important objective and an important target for research. Number 2 on the list was even more specifically relevant to the issue of precision pain management. That is patient treatment matching. Beyond the consideration of availability of these approaches in the environment, does a specific VA facility have all these things available? Very few probably have all of them. So access or availability is one issue, and then patient preferences is the other important issue that we would say we would want to consider if we're going to be patient-centered. And you can look down this list at other questions that are important to address as well. So as much evidence as we think we have, there's much more that needs to be done. In fact, when the fourth working group, which is the one I want to highlight today, that focused on models of pain care delivery, we realized that there were no systematic reviews of models of care that have been published. And we requested what's called an evidence synthesis program review in the VA. The VA Health Services Research Program sponsors centers that conduct these rapid evidence synthesis reviews. And so we got VA, HSR&D, to fund this review on models of care. And you see the focus here was on system-based mechanisms to increase uptake and organization of multimodal care, focus on adults with chronic musculoskeletal pain, particularly relevant to the VA, and interventions that were integrated in primary care or potentially could be integrated in primary care. And so this review was conducted. Paper now on this topic is now actually in press in a special issue of the Journal of General Internal Medicine that will be coming out early next calendar year. So the group that did this review, led by Peterson and colleagues, focused on this list of different models of care that you see here on this slide. And I put up the chronic care model because this is probably the model of care that's most widely disseminated or thought about in the world of health services research anyway, by Wagner and others. It's been around for a long time and really does form a conceptual model that's been used in a lot of work. But you see other models of care. I'm going to later have a slide about the step care model, which is essentially a systematic escalation of intensity of care as needed. So the group found 10 studies that were reasonable to be considered in this context. They found evidence for 5 models. 4 of the published trials actually were conducted in the VA, which was interesting to observe. The one that many of you in this room may know about is the StartBack trial that was conducted in a civilian population. And at least one or more of the other reviews, even though there were veterans in the sample, also included non-veteran samples as well. They found that trials that included, in this diagram on the right side for all of you, those seem to be the key components that cut across these intervention studies. And you see here some of the results. That the best trials in this area did show effects on both pain intensity and pain-related functioning for 9 to 12 months following the delivery of the intervention. And the group argued that the nature of these models and the nature of the studies helped support their adoption in VA. I have to say that although there's a lot of talk about these models in the VA, and some VA facilities have adopted various aspects of these models, there's still relatively little uptake of these models at this time, even in an integrated healthcare system in the VA, and even despite very strong evidence from papers published in JAMA and other high visibility outlets. Skipping full speed ahead, I came across this article that was just recently published in Pain. It's essentially a review consideration of interdisciplinary multimodal pain therapy and ask the question about whether it really is the gold standard. And the bottom line is, I put on this slide the research agenda here. And you see that nobody would argue that there's a need for research in each of these domains. I think the group that published this paper did a good job at creating this list. And I highlight here, for the purposes of the talk today, the need, again, to focus on subgroup or moderator analyses, maybe in the service, at least today, of framing that as an opportunity to think about precision, the concept of precision pain management. So is there evidence to support a patient treatment matching or prescriptive approach to chronic pain management to optimize outcomes? And I'm going to talk mostly about psychosocial interventions, but frankly, I think the same thing could be applied to the broader array of maybe even both pharmacologic and non-pharmacologic approaches. So everybody that gives a talk like this, I think, should have one totally unintelligible slide. This is mine. I developed this slide with a colleague many, many years ago and continue to use it. It's very bright and colorful anyway. I kind of grew up thinking about a diathesis stress model of diseases, particularly chronic diseases, early in my career, depression and others, where this has had more legs. So we've thought about the idea of a diathesis stress model that really captures the essence of a biopsychosocial model too, and thinking about the development and perpetuation of the chronic pain experience. On the right side of your slide, I think we would likely all in this room accept that the experience of pain chronic pain is complex, includes not only the underlying painful condition, but also pain itself, as well as some aspects of physical and emotional functioning. The idea here represented in this slide is that pain, the experience of chronic pain and its development, if not or perpetuation, if not development, occurs in a social, environmental, I'm a social learning kind of guy, so a social learning environment that takes into account both an individual as a person across, for the purposes of this slide, artificially delineating buckets of biology, cognitive functioning, behavioral functioning, and affective functioning that interact with the stresses or challenges of the experience of a pain, an acute pain experience, for example. So taking into account individual difference variables that are challenged by the stress of pain, and it's through those interactions all occurring over time in a social learning environment that determine the experience of pain at the time, for example, that a patient comes to us in a clinic. So are there implications of this model for thinking about a patient-centered prescriptive approach? I believe there are. So we can think about multiple targets of intervention, managing the underlying disease, arthritis, for example, trying to address issues of analgesia and pain reduction, trying to target deficits in functioning and emotional well-being, all are important goals for treatment. And I think we can do that by targeting the outcomes themselves more directly, use of analgesic medication, optimizing analgesics, potentially in a patient-centered, individually tailored kind of approach. This has been done by Dobsha, Kurt Kroenke, and others in some of their trials, for example. We can also try to address some of these identified diatheses or relative weaknesses of the individual across the domains of their biology, cognition, affect, and so forth. Somebody that has a propensity biologically to depression may require a different kind of treatment than somebody that doesn't, for example. And we can also think about using what we can learn from a comprehensive assessment informed by that model in identifying strengths of the individual and trying to reinforce their strengths in adaptive coping, for example, or other aspects of their life. And we should do this all in the context of addressing their social and environmental context. And this leads me into just saying for 1 minute that much of the challenge here is looking at our population and realizing that among all Americans that, or people around the world that experience chronic pain, there are particularly vulnerable groups, veterans being one, but socially disadvantaged groups, minorities in this country in particular, people that live in impoverished areas are particularly vulnerable to chronic pain and, by the way, the opioid epidemic. And so if we don't take into account those environmental factors, I think we're missing an important opportunity. So this is a model that we've espoused in the VA. The VA actually, former Undersecretary for Health Ken Kaiser, that name may mean something to you, as early as 1998, labeled pain as a high priority for the Department of Veterans Affairs and launched a national pain management strategy. I was privileged to be the founding director, national program director for pain management in the VA, starting in 2006, and have been even involved before that. By 2009, we put in policy this model of stepped care, which really at the time I thought was quite revolutionary in suggesting, really acknowledging, frankly, that pain has to be addressed in the primary care setting if it's a population health level approach. We can't think that we're going to address the problem by building more and more specialists to address a population health level problem. So at that time, and I think continuing now, a lot of the effort that's informed by this model is a focus in primary care. But consistent with this model, the idea is stepping up the intensity or the nature of care, maybe the increasing use of less and less conservative, using mostly conservative treatments in the primary care setting, more invasive or risky interventions as needed due to things like factors like complexity, comorbidities, the treatment refractoriness of the patient, and risk. And it seems to me that one could frame this, if you will, in a way as this idea, consistent with an idea of precision pain management. It's not the same use of the term, but I think it does speak to the idea of tailoring treatment related to certain kinds of factors and starting with a population level approach in primary care and then building on that beyond. I do want to point out that at some point, really Matt Gallagher, my successor as the National Program Director, really put in this floor, which I totally support, which is pain care occurs mostly in the family and in the home. It doesn't occur in interactions with healthcare providers. And so thinking about how a system like the VA can help support, or really any system, can help support people in developing an adaptive approach to living with chronic pain, managing chronic pain. We talk about pain self-management, that we needed to emphasize that, and that interactions with the healthcare system probably are best served by trying to support the individual in their development of an adaptive pain self-management approach. And so that's what this slide is really emphasizing, is what I think is particularly important are those efforts that really are grounded in an underlying concern, as again highlighted by the IOM report, the National Pain Strategy, and again in the Federal Pain Research Strategy, to really focus on patient-centered self-management. This is a slide from a recent study that's actually currently a manuscript that's currently under review, looking at the use of different approaches among veterans in the VA Connecticut healthcare system. And really, the bottom line was looking at the uptake of these approaches, but also who are the people that are utilizing different kinds of approaches. A glimpse at maybe it's an issue of access, but then that doesn't necessarily explain potentially racial or age differences across the system. Potentially more likely is patient preferences, but it may be something beyond that. It may be related to something about the experiences that people have learned about the effectiveness of these different approaches. So we can start glimpsing at a little bit at what are some of the predictors, if you will, of the use of different kinds of approaches. I'm not going to highlight these. The highlighted in red are those significant findings in this relatively large cohort. This is all from self-report data that were collected as part of a wave of data collection in what's called the Women's Veterans Cohort Study, about 800 veterans from the most recent wars in Iraq and Afghanistan. So when I was young, I worked with Dennis Turk at Yale, who then went on to great things and is now, and has been for many years, an endowed chair at the University of Washington in their pain center. We really focused a lot on cognitive behavior therapy, this new idea that maybe thinking had something to do with pain, and the idea that a cognitive behavioral approach that had been applied in other areas like depression and anxiety might be relevant to pain. We didn't publish the first outcome study. Judy Turner, a colleague, a psychologist, did that. She beat us to the punch by 4 years. We published a very small trial that was published in the first issue of the new Clinical Journal of Pain back in 1986. The bottom line here is that even then, I think we were thinking about CBT as an inherently flexible approach that could be individually tailored based on a comprehensive assessment that occurred before the treatment. And it could be manifest by things like helping people develop individually tailored goals that were value-driven and meaningful for them, as well as trying to shape a 10-session structured cognitive behavior therapy approach to relatively emphasize different aspects of that approach. And ultimately, I think the idea was to really address the right side of that earlier diathesis stress model and address not just pain, but functioning and emotional well-being. So even then, I think, and moving full speed ahead, we understood that cognitive behavior therapy was not a technology. It was a psychotherapy that was really founded in core principles of the therapeutic relationship and a supportive, respectable, compassionate understanding of the person with pain and a validation of their pain that could support the use of the establishment of the therapist as a behavior change agent. And again, this idea of an inherently flexible approach comes out. This is a slide that highlights the kind of approach that we used even then for setting specific behavioral goals. And I'd highlight that a colleague now at VA Connecticut and Yale, Alicia Heapy, who's doing some great work on this front, has really further helped us categorize different goals. And this categorization actually could be used in the context of CBT or other therapeutic approaches to help guide some of our tailoring. Of course, I want to acknowledge that there are a broader array of psychological interventions beyond cognitive behavior therapy that have shown over the last several decades and with increasing evidence of their efficacy or even effectiveness, even when delivered alone, if not in the context of a multimodal treatment approach. Having said all that, and looking at meta-analyses after meta-analyses and systematic reviews, we come with the fact that these approaches all deserve our attention because they have demonstrated efficacy and appear to be helpful for at least a minority of people with chronic pain, targeting improvements in pain, functioning, emotional well-being, et cetera. But there are many challenges, and you see them listed here. The ones that I focused on in my research were really about improving access, engagement, reducing dropout and adherence to treatment recommendations, because we really can't think about interventions that improve outcome if we don't get people through the door and fully engage them. This led to a line of research that was informed by Prochaska and DiClemente and others' trans-theoretical model of behavior change, and particularly the stage of change concept. That is, that people vary in their readiness to learn or adapt a pain self-management approach, participate in things like cognitive behavior therapy, and so forth. So that led us to developing a measure. I've been here talking with some other colleagues that have shown interest in this measure called the Pain Stages of Change Questionnaire. We thought that this would be validated if we could show that this measure had predictive validity in terms of predicting outcomes. Ultimately, I'll show you that it really didn't, but it does have important implications for what we're talking about today. And here's some examples of the items of each of the 4 subscales of the Pain Stages of Change Questionnaire. Bottom line is that pre-contemplation is people that really don't think that this kind of intervention, pain self-management, is appropriate for them, versus people in the action and maintenance phase who potentially are more ready to make changes in their life. Early on, we published a paper with Roberta Rosenberg, and where we, and this is a very busy slide, but the bottom line is that we compared the utility of this measure to predict treatment completion, in this case, cognitive behavior therapy, relative to a broader array of sociodemographic variables, outcome measures like pain intensity, pain disability, as well as pain descriptor variables. The only measures that we found in this study, and this has been pretty consistent across 30 years of research, was this Pain Stages of Change Questionnaire. So in terms of at least predicting engagement in treatment, many of the putative candidates, like disability, pending litigation, really haven't panned out for us. The summary of the findings, which have continued long beyond 2004, were summarized in this review published with an Australian colleague in the Journal of Pain in 2004. Bottom line is that the PSOCQ the measures did not predict outcome. However, they did predict treatment engagement and completion, and importantly, even pre-contemplators, and here's the take-home message, who appeared to be totally unwilling to engage in cognitive behavior therapy or adopt a pain self-management approach, if they were successfully engaged in treatment, were just as likely to accrue benefit as their colleagues, their peers, who seemed more ready to adopt that approach at the beginning of treatment. And finally, shown by me, John Burns, and others in multiple studies now, that degree of change or adoption or change on the PSOCQ, that is increased action and maintenance scores over the course of treatment, is associated with change in outcomes. So people that become engaged somehow and accept or develop beliefs more consistent with pain self-management actually are the ones that accrue the greatest benefits of at least cognitive behavior therapy. We then tried a variety of strategies to use this to change the design of CBT. One study was integrating CBT in a primary care setting with a collaborating primary care provider, and modifications to CBT to enhance use of things like motivational interviewing to promote engagement. The bottom line was it didn't work. It didn't have any better effects than an approach that's CBT delivered in a tertiary care setting. But what we did observe was that readiness to change measures, particularly contemplation in this case, did seem to be associated with adherence to therapist recommendations for skill practice during a structured CBT kind of program, and that was associated with goal accomplishment and other outcomes, leading us to think that really the action is something about people's participation in the treatment and their engagement in learning and their willingness to engage in skill practice specifically. This led us to another study to even more specifically examine process of change. So we were interested in people's preferences for engaging or learning any of the pain coping skills that we were offering, kind of a menu of pain coping skills as part of a CBT treatment, and actually tried to match people in one condition to their preferred pain coping skills, and in another condition, actually through a mathematical algorithm, give them their non-preferred or least preferred pain coping skills, and also examined a variety of process variables, including readiness to change, as well as working alliance or therapeutic alliance, self-efficacy, and other potentially putative mechanisms of change. The bottom line is that there really was no support for our hypothesis that a tailored approach would be enhance engagement or participation. Ultimately, the first bullet here is probably the most important. We found that people that said that they were interested in learning any one of the 9 coping skills that we offered were likely to say they'd like any of them, right? So the discrimination that we were able to offer people at the beginning of treatment, information we could give them about these pain coping skills really wasn't helpful to them in making discriminations about what they valued or might appreciate or might find beneficial for them. It's fair to say that once people were engaged in the study, signed consents and participated, we had very low dropout and very high rates of adherence anyway, so it's not a lot of variance to predict. This slide really is the summary here today. It's a very busy slide, but the bottom line is in a study, a series of analyses by John Burns, really the lead author on this paper, who's at Northwestern. We found that even though there was some evidence to support specific mechanisms, really related to the pain stages of change, that once you took into account things like therapeutic alliance and self-efficacy or expectancies for benefit of the treatment, the more specific effects really kind of washed out, right? They all seemed important, but these more specific mechanisms weren't more important than more general mechanisms that have been shown to be important in other areas of psychotherapy research. The bottom line is this idea of patient treatment matching has been around for a long time. Dennis Turk and others impressed that Bill's clusters from opera looked very similar to the clusters of Dennis Turk from a purely psychosocial measure. Another one that I was involved in developing with Dennis Turk, the West Haven Yale multidimensional pain inventory. So the idea is not new. The evidence supporting the ability to identify variables to prescribe certain kinds of treatments relative to another is really quite limited. Or the idea that certain subgroups will benefit from certain treatments relative to others. It's kind of hit or miss is my summary of that literature. So really the bottom line is there's minimal evidence that we, at this point, at least in the psychosocial domain or the non-pharmacological domain more broadly, that we can think that demographic or clinical characteristics, this idea of phenotyping, really can help guide us to be more prescriptive. That's not to say that we don't do it in practice, right? Clinicians make these judgments every day. But at an empirical level, the body of evidence is really not that supportive. And I'm going to end by acknowledging a new opportunity that's come our way. The NIH, the Department of Defense, and the VA have done something extraordinary. They've partnered in a funding initiative of a new pain management collaboratory modeled after a, quote, civilian collaboratory, not focused on any specific condition, that's been in operation at Duke, coordinated at Duke now for several years. So we just recently received the funding notice. I'll be working with colleagues at Yale as the directors of this new enterprise. The NIH, VA, and DOD, and actually many institutes and centers across the NIH have brought money to bear on this initiative, where we will be coordinating the conduct of 11 pragmatic clinical trials of non-pharmacologic approaches to be conducted in military treatment facilities settings and VA settings. And in that context, there's an incredible opportunity to do a lot of things, learn about pragmatic trials and their conduct, and address issues of the study design, ethics and regulatory issues, use of the electronic health record, and so forth. But the one that I'd highlight here is this great opportunity for sharing data across these trials and building a database to actually develop phenotypes or examine the possibility of phenotypes and look at predictors of outcome or at least moderators of effects in a way that we really haven't been able to do previously. So the conclusion here is the complex nature of the experience of chronic pain, pain more broadly, and existing theory and empirical evidence supports an integrated, biopsychosocially informed, patient-centered, multimodal, and interdisciplinary approach. Theory and research to inform a precision pain management approach is, at least in this domain, is in its infancy and should focus on addressing gaps in how such an approach can inform and enhance the effectiveness of an integrated plan of care. I appreciated other people putting up this slide. I want to do my pitch. You know, at some level, this is about studying mechanisms. And so I want to also encourage people to think about attending the American Pain Society. I wasn't paid for that. And I want to thank you for your interest and attention. I think maybe one question.
3 minutes.
Well, thank you very much, Bob. I'm curious on your thoughts on delivery and the degree to which, and I think we all recognize that time, patients' time and finances have potentially great impact on adoption of different modalities of treatment and what we can provide. So I'm just curious, from the various studies that you've addressed, to what degree have patient socioeconomic and time factors been accounted for, and how do we begin to think about delivery in various settings where time and money become less of a modifier of outcome?
So I've mostly lived in the world of the VA where issues of money for veterans is less of a concern. It's not a concern at all, but it's less of a concern because it's a single payer system. I think most of us would recognize in the real world that this is money is a huge barrier. And you know, these issues were addressed, I think, very well in the IOM report, the National Pain Strategy, and are an important target. I think, you know, so that's one part of it. The issue of access, of course, is another issue beyond money. Geographic barriers are hugely important in the VA because the majority of veterans actually live in rural settings without access to a healthcare, you know, even a community-based outpatient clinic. This VA is really focused on addressing access. There are huge challenges. So on that front, I think we're starting to see the emergence of the use of technology to deliver some of these interventions, for example, CBT-like interventions, remotely, virtually, and I think that's a good opportunity. In terms of the evidence, you know, so there's growing evidence for some of those kinds of interventions, but really the issue that I think at the heart of your question is, what is the evidence about these barriers? How much do they drive people's selection or choice of interventions? I don't think we have any evidence, as far as I know, about that. And I think that's hugely important. If anybody asks me what I think the biggest issue in the pain world is, it's money. If any of you are here from CMS or have colleagues in CMS, I think that's where we need to put a lot of our effort.
So, Bob, I have a related question. Is patient preference for treatment, and how does that reflect either response, or has that been looked at in the setting of some of these trials at all?
So I think not explicitly. I think we assume that patients are making, they're making decisions, particularly interventions that they're getting out of the mainstream, like choices for many complementary and integrative health approaches, where they're having to pay out of pocket, right? Nobody reimburses them. You know, most of these interventions don't have CPT codes. They don't have billable codes. And so we assume that that's the case, that they're making decisions based on, you know, what Aunt Sally or their friend encouraged them to do, or their preconceived notions about what these interventions are. I think there are, it's a great need for us to study patient preferences more specifically. As I said, we tried to look at that a little bit in that tailored CBT study. And the bottom line was that, and I've talked about this with others, you know, in the little bit of time at the entrance into the study, the information you could give them about these treatments may not be sufficient to help them distinguish whether they'd be interested or prefer one versus another. So it may be that the bottom line is where these services are. Are they available to their community? That's much more, much bigger driver. But I do think that's important avenue for research, and yeah, probably should stop. Thank you.
Speaker will be at 10 minutes to the hour. Take a short break real fast.